Welcome everyone to the Cicely Saunders Institute International Women's Day 2022 event. Step Up, Step Out, LGBTQ+ women in palliative care research and practice. My name's Debbie Braybrick and I'm a research associate at the Cicely Saunders Institute, which is within King's College London in the UK. My pronouns are she, her. And today, in terms of my appearance, so I've got shoulder length brown, kind of slightly greying hair, I'd say. It's curly. I've got kind of very brown, very pale brown, kind of tan skin, and today wearing a kind of mustardy jumper. My team's background is the LGBTQ+ flag, and on it you can see the hashtags for the event today, so for International Women's Day, which are hashtag Break the Bias and hashtag IWD2022, and also the Twitter handle for the Cicely Saunders Institute, which is, oh, that might not be on this slide actually, but it's at CSI_KCL. Just to say, if you want to tweet today, if you could just use camel case on the hashtags, which means that each word is capitalised. So for Break the Bias, you'd capitalise the B, the T and the B. And this just makes it more accessible really for everyone. We also have live captioning turned on for everyone who wants to use that today. So, as you've probably gathered from what I said so far, the theme this year is Break the Bias, and really this speaks to a world that's free of bias, stereotypes and discrimination, one that's diverse, equitable, inclusive, and where difference is really valued and celebrated. So the Equality, Diversity and Inclusion team at the Cicely Saunders Institute are always pursuing this. And we saw this really as an ideal opportunity for us to learn and reflect on the experiences of LGBTQ+ women in palliative care research and practice. So we're learning and always seeking to be more mindful in both research and practice of intersectionalities of experience. Some of you may have heard that term before, but intersectionality is a term coined by Professor Kimberly Crenshaw back in 1989 to describe the oppression of people who are African American and women. In the years that followed, it became relevant to help us understand how different aspects of a person's social and political identities overlap and interact, including sexual orientation and gender identity, and the way these overlaps work to create really unique experiences of marginalisation. Jump years forward, and this concept is still relevant and important today. So today we've got a brilliant lineup to help us think more about people who are both LGBTQ+ and women in palliative care practice and research. First of all, we'll hear from two speakers, Dr. Donna Wakefield and Dr. Carey Candrian. We'll have some time for questions after each. And please do submit your questions via the Q&A tab. And if you like that question, there's also an option to vote for it, just so we know, kind of we can keep a track and we know which questions are popular with the audience. And we'll then move on to welcome two further speakers. So Doctors Katherine Bristowe and Elizabeth Day, and that will be for our expert panel discussion. So without further ado, I'd really like to welcome our first speaker, Dr. Donna Wakefield, and she's a palliative medicine consultant at North Tees Hospital. Completed a master's in clinical research at Newcastle University, and research interests include inequalities, bereavement and end-of-life care. So thank you, Donna, and welcome to the floor. Perfect. Thanks so much, Donna.
And thank you for the introduction, Debbie, and thank you so much for inviting me here today to talk about LGBTQ women in palliative care. So we're all describing ourselves. So I am, I've got long ginger hair, pale skin, blue eyes, and I'm wearing a dress with the Northern Lights on. So first, I'm going to ask you to reflect on what lens you see things through. Often our knowledge, and when we attend talks and lectures like this, it's through the lens of a white, able-bodied, cis heterosexual man. And like these pictures, your view of the world without ensuring diversity and wider representation would be a very sort of grey and bland place. And that's not a slight towards, this is one of my favourite graphic artists, Escher, and he's done these amazing lithographs and woodcuts. But I really love art, so I really tried to incorporate that in some of my slides to make it a bit more interesting. Moving on to the next slide, you know, having such diversity and colour can really add to the world and what we have to offer. This artwork is by Roxana Hall, who is a queer artist and feminist, and all of her artwork depicts women who refuse to adhere to societal norms or expectations. I particularly like the artwork on the left, Laughing While Leaving, because I think it looks like me and my girlfriend, who's pictured at the bottom there. But even I myself must acknowledge that although I am a queer woman and within a marginalised group, I do have significant privileges myself. I'm a white, able-bodied cis person, and so I don't face the discrimination of intersectionality, which is a very hard word to say. Thinking about life as a palliative care healthcare professional, I've had many years of advanced communication skills training, and we've been taught to have these delicate conversations with patients, from anything about fears about dying, to very intricate details about people's latest bowel movements. Yet I find that quite often people feel quite uncomfortable asking, so who is this that you're here with? This image on the right here is a photograph of Barbara Hammer and her partner, and she was a famous artist and filmmaker. She came out in her 30s and spent a whole career doing lesbian art and films at a time when it was very much frowned upon. And she shared a lot about her experiences of being a gay woman with cancer, and really raised the discussion about what it was like dying as a member of the LGBTQ community. I've looked at the last slide and thought, that's not true. I don't think that people have a problem asking about who people are there with, but I've seen it quite a few times myself. I've got some numbers here suggesting how many LGBTQ people there are, but to be honest, we just don't know because population level data isn't collected. People often assume that people are cis and heterosexual until proving otherwise, and they have very perceptions about what gay people look and act like. I think back over the past 9 years working within palliative care, and I think, there's been very few LGBTQ people that I've looked after. But is it just a case that I didn't know? I remember a few examples that have stayed with us, one being of a lady who was in a hospice I previously worked in, and she had what it looked like an older lady in the bed and a younger lady holding her hand. And I remember a healthcare professional asking, how's your mum today? And then them being quite upset because it wasn't a mum, it was a partner. And then on another occasion in the hospital, when I was a junior doctor, a healthcare professional being very shocked when they went to wash a trans woman. They came away and it caused a lot of discussion, should the woman have warned us? But I don't think it's a reasonable expectation that people should have to come into a hospital environment and describe the genitals to us. It should be something that we're much more comfortable with in discussing openly, rather than in a situation of being heterosexual and cisgender until proven otherwise. So over the years, I've done some educational sessions, and the problem with educational sessions is that people self-select. You end up getting people who are already good allies and already have good knowledge. So I found that baking cakes really attract a wider audience. It was quite enlightening that people didn't know what they didn't know, so they wouldn't know to ask. There was a lack of awareness about what pronouns are and how to use them, and the impact of discrimination, and what impact that has, that's long lasting. It made us reflect back at medical school, and I think we didn't have a single session on LGBTQ inclusive healthcare in the whole time I was there that I can remember. And I think the only mention we had of gay people was in exams, as a clue that that diagnosis might be HIV related. And I went to medical school 14 years ago, so when I finished, and I truly hope that there has been some progress since then. As I said, people that have come to this talk today have probably self-selected as members of the LGBTQ community themselves or allies, but you might be surprised that when I talk to people who aren't, how surprised they are at the recentness of events. People think that discrimination against gay people is something of the past, but the entire time that I was at school, school weren't able to mention that gay people even existed because of Section 28. I remember when I was at school, having been hassled by a group of other kids, and then when we were pulled up to see the head of year about it, I was told that, you know, for the reasoning, the teacher was disappointed in me, and that the people who were, you know, trying to intimidate me were, you know, being good Catholics, and I really hope that there is some progress, and I hear that there is, from my girlfriend who is a teacher, in finding that things are better in schools and things are being taught about being more inclusive. And there's just some of the events that have been within, you know, my lifetime, being declassified as a mental illness, the Civil Partner Act and the Equality Act, and then the ability to get married. And on the right here is a photograph of the first women in Northern Ireland to get married, and that was only almost exactly 2 years ago that they got married. So it is very recently that things have started changing and that gay people are getting the protection that they need. So I welcomed the opportunity when I was invited to do a literature review summarising some of the recent evidence over inequalities for LGBTQ people accessing oncology care and palliative care in Current Opinion in Support of Palliative Care Journal. There is a lot of things I pulled out through doing this literature review, but one of the main themes that stood out to me, and something that I've experienced in real life, is that people didn't ask about sexual orientation or gender, and there was 3 key reasons for this. Some felt that they lacked the knowledge of how to ask, and they didn't know the language to use, and they didn't want to cause offence. And I've seen that, you know, does happen a lot in the settings that I've worked. Some questioned why they should ask. They thought that it wasn't relevant to know, and you know, it wasn't any of their business. And hopefully in the minority, people who did not want to know because they felt that it conflicted with their own personal beliefs. A big degree, it shouldn't matter to people. It shouldn't matter in everyday life if you know, were walking down the street, and I'm not suggesting that LGBTQ people should have, you know, the onus shouldn't be on them to all identify themselves. But as a healthcare professional, you need to be able to provide and consider the psychosocial impact of living with a stigmatized identity and how that can have a real impact on physical health. If people have experienced prejudiced behaviour, they might avoid seeking healthcare in case they receive worse treatment. This might lead to people presenting with more advanced disease and not being able to have treatment. Also, the impact of living with discrimination can lead to stressor behaviours with an increased rate of smoking, alcohol, and mental health problems in the LGBTQ community. And also, if you're a healthcare professional, you always consider patients' social support and what network they have to support them. LGBTQ people are more likely to be living alone, they're less likely to be married, less likely to have children, and they may be estranged from biological family. I've got a book on here by Kim Aquaviva, who is a professor of nursing in America, and a lot of you might have heard about her work before. She and her wife Kathy Brandt, who was also a palliative care expert, documented the care and challenges encountered for them whilst Kathy was dying of cancer in 2019. It was really humbling to watch their last days together on social media. So Professor Aquaviva has got experience of both being a professional and being a relative herself. And on the right here is a book which I recommend to some people as a practical resource for improving skills when providing LGBTQ inclusive hospice and palliative care. Another good resource for people on it's on the left here is published by Marie Curie, and it's Hiding Who I Am, and that has a lot of valuable information in it, and just one of the quotes from it is in the middle there. So patients have the dilemma: when is it actually safe to come out to a healthcare professional? So one thing that I did find helpful was having the rainbow badge scheme, and there was the NHS rainbow badge, and then later the Marie Curie brought out a rainbow badge as well for use across their hospices and for their staff. And this was actually helpful for people to see that person has signed a pledge. They're showing a visual indicator that they are an ally and that they're a safe person to come out to. Unfortunately, during the pandemic, and I say unfortunately because it's unfortunate in some ways and not in others, that people wanted to show support for the NHS by using the rainbow symbol, which is all very good and well, but now there's a lot of confusion, and I see this argument on social media a lot, is that people think now that if you're wearing the rainbow badge, that is a sign for the NHS, and the meaning has kind of got lost a bit. And I think during the pandemic, it's a particularly hard time for LGBT people. As I said, people are more likely to be isolated and not have support. And also with so many deaths, there is the problem with same-sex couples is that you have the problem with disenfranchised grief, where people may not get the support they need. So on the left here is just a picture of some of my colleagues and me with our rainbow badges on, which will kill me for including in the talk. But yeah, I still wear my rainbow badge, but there is an issue of that it might not be recognised to serve the purpose that it was meant for anymore. So I started to think about data because I'm really interested in data, and I wanted to look at how many people were we actually seeing in palliative care who are LGBTQ. The problem was when I looked for data that there actually wasn't any, because we don't routinely ask about it. And it wasn't just a case of the palliative care team that didn't. The hospice didn't, the hospital didn't, and even primary care didn't. When I talked to my colleagues in primary care, they looked at read codes that they used for coding, and there is no mandatory question that asks what people's sexual orientation and gender are. There are some codes available, but they are very, very outdated terms and tend not to get used. The problem is, if you don't record and you don't have any data about it, how can you work towards improving and working towards equality? This led me on to thinking more about why we need to give careful consideration and make sure that LGBTQ people can access palliative and hospice care. And I collaborated with some of my colleagues who are here today, including Debbie Braybrook, who introduced me, and some other members of the EAPC Task Force for Improving Palliative Care for LGBTQ people. We sat down and we wrote this editorial for Palliative Medicine Journal, and I was really happy that I was able to do this and raise the issue of why it is so important to spread the word about how this is a really important issue, and not just for us who have a vested interest, but the wider palliative medicine community. Quite conscious that today it's meant to be a celebration of International Women's Day, and I know some of this presentation has been a little bit negative in about the bad things and what's lacking in palliative care and even in society in general. So I wanted to try to pick out some things that I thought were positives. So one of the positives is that there has been a recognition that there is a gap in data, and that is music to my ears, because the more data, the better. Some of you may have realised that in 2021 we had a real significant milestone in England and Wales when the 2021 census included, it was a voluntary question on sexual orientation and gender, and that's something that's really important. Also, I've got a leaflet on the bottom there about great progress that the LGBT Foundation have made in raising the profile of the importance of collecting data on who we have, how many people are LGBTQ, and it has lots of guidance on for people in healthcare, how you can gather data sensitively. I've got this book on the top here, which is a really brilliant book that came out just this year by Kevin Guyan, on the importance of really explaining why nobody wants to be categorised and othered for the sake of it, especially for some things like gender and sexual orientation, where it's not easy to categorise it. People may feel that they're on a spectrum. You know, ideally we would ask people to self-describe what their orientation is and gender is, rather than fitting them in a box that you have created for them. The problem is that if you get people to describe, that is quite complex, and I think for the first step, you know, even getting broad categories would be a step in the right direction. And this book, you know, it is really good at explaining why that if we are on a quest for more data, that we make it really clear the purpose of why, and that gathering the data will directly improve the lives of LGBTQ people, rather than just be gathering for gathering's sake. And I think that's a real step in the right direction. Also, the more attention that LGBTQ sensitive palliative care gets, the better. So I was really excited to see that Palliative Care and Social Practice Journal just had a special edition on palliative care for LGBTQ people and their families. There was also a recent call for equity-orientated palliative care manuscripts for palliative medicine, so that won't all be LGBTQ, but it certainly welcomed articles that were going to be suitable, and hopefully there will be something included within that special edition when that comes out. Just even not specific to palliative care, I'm thinking to patients who have been sort of othered all of their lives and made to feel like, you know, it needs to be kept secret, their sexual orientation. So having more queer visibility, even in the media, is something that's really important. Now, I'm not saying that we should, you know, be aspiring to be some of these characters, since some of them are about murderers, but it's just generally finding that you don't have to go to some obscure screening service to find people who are like you. You don't have to be searching the internet to find any sort of program that includes same-sex couples in. So these are some of my favourite over the past couple of years. And you know, I've got friends who you know, aren't gay, who have really enjoyed watching Gentleman Jack, enjoyed watching the ending of Line of Duty, when Jo got her house with another lady, and I especially enjoyed Ratchet because not only is that got a relationship of two queer women, it's also being acted by queer actresses, so I think that was you know, really good to see. And also, even in books, some of these are of recent, some not so recent. Books that I would recommend. I love a book that just happens to have a character that just happens to be lesbian in it, rather than the whole focus being about somebody's coming out story. And so these are some of the books that I've read. And also, if you know, you have colleagues and friends who are questioning why it matters, we can do better than this. It's really good. It has, you know, 35 very short chapters of the importance, and it also gives a global perspective. So, you know, it's going back to privilege in this country. We do have some rights, whereas it's easy to forget that being gay is still illegal in lots of parts of the world, and this book does give some insights into that. And then I'm also a mother of a young daughter, so I think it's really great that there are some now more inclusivity in books with same-sex parents, and that, you know, my daughter grows up not thinking that it's something unusual to be gay. And now equity and diversity is front and centre. I was really interested to see that the theme for the next European Association of Palliative Care Congress in 2023 is going to be in the Netherlands, and their theme is equity and diversity. So I hope that that is going to be very inclusive and have some sessions on, you know, LGBTQ inclusive palliative care. So in conclusion, I'm really honoured to be given the opportunity to speak here today, but I would go back to say that, you know, I'm on an expert panel, but I wouldn't describe myself as an expert. I really want to provide some positive representation as a queer woman in both medicine and working in palliative care. People say that, you know, you don't have to share that, you know, you are gay, you could keep it to yourself. It's not relevant to your role, and I think to a certain degree is right. I could keep it private. Nobody's saying that everybody who is a gay healthcare professional has to tell everybody, but I grew up not knowing many gay women. I grew up being told that it was wrong and that it was frowned upon. So I think, you know, to be able to be a good role model and be someone that patients feel comfortable talking to and that colleagues feel comfortable asking questions to, you know, I think that's really important to me. My hopes for the future are that we can move beyond tokenism and EDI and have some meaningful engagement. I hate to see it when people say that it's used as a tick box exercise. You know, there'll be a talk, but nobody will turn up. But, you know, tick the places done their talk for the year. So, you know, they're fine. That's not the point. The point is that we want to have some engagement and even, you know, all discussions helpful. Also, I find like in research and healthcare that we get trendy topics that become very topical over time, and you know, that's becomes the flavour of the month to talk about. I hope that this is not one. I hope that, you know, LGBTQ inclusive healthcare, especially in palliative care, when we're looking after patients, that they're in a very vulnerable time in their lives, that they can feel safe to be themselves and share with us, you know, who's important to them, and you know, let us provide them with really good quality holistic care. I hope that we can start to gather more meaningful data, even if it's initiated in a very small way. We can't provide equity of care if we don't have any data at all. So any data is a step in the right direction. And also, just to go back to the start, encouraging you all to think critically about the, you know, how you view the world and what lens you're using to see everything, and you know, seeing if you can see it from somebody else's point of view. So thank you for letting me join your International Women's Day event. This is on the middle. I have 4 generations there. So I have myself, my daughter, my mum and my nana. So that is 4 generations of women in my family. And then, of course, on the left is my girlfriend when we visited, where Anne Lister went with Anne Walker to seek the sacrament in York. Obviously, gay marriage wasn't allowed then. It's allowed now, although still not in church. But I thought that is a nice photo to end on. So thank you very much. I can usually be found on Twitter having more debates and discussions about this, but I'll hand you back to Debbie now. Thank you.
Thank you so much, Donna, for such a lovely, personal and thought-provoking presentation. I really appreciate you sharing all of those incredible insights. And I think what it really highlighted to me was kind of how many different layers there are in terms of making sure that care is kind of inclusive and equitable, and that ultimately people are provided the care they need. I think one of the things that kind of really shone through for me was you spoke a lot about the importance of data, collecting data, and I wondered kind of from your perspective and kind of in the work you've done, while there is beginning to be some recognition of that importance, what might be done to help, I guess it's kind of a bit of a two-pronged question, but help healthcare professionals understand the importance of that, but also assure patients of the reason that those questions are being asked in care?
I think it's difficult, and I think, you know, you're starting from a baseline where we don't have any information and we don't routinely do it. We don't routinely ask patients. And I think, you know, I've thought about this a lot, and it is hard when, especially when patients are coming to a hospice or into palliative care, to ask such delicate questions. But, you know, we're asking so many other delicate questions. I think the best time to ask people would be when you first meet them, and make it optional. You know, people don't have to feel that they have to answer, but if you had it, I guess, in a written down format of, why am I asking this question? I'm asking this question because it's important as part of providing the best quality care for you. But, you know, it's optional of whether you answer. You know, we're not going to make you tell us, but, you know, I think having you know, asking who's the most important person to you, and remember to ask that question, rather than, I still saw people, you know, when they admit patients, say, you know, what's your husband's name? And I had it myself. I went for an operation, and they said, like, can I take your husband's details? And, you know, it's just that automatic assumption that some, like, you see a woman and that they will have her husband. So I guess I'm not sure that answers your question, but asking in a tactful way, having maybe some written literature about why it's important. And I think really having things that show that it's a safe place is really important. So if you're coming into an environment, having posters on the wall that show that, not focused on LGBTQ issues necessarily, but if we look at leaflets, it all shows heterosexual couples normally. If it just happens to have a picture of a same-sex couple in a poster or in a leaflet, it shows that, you know, that is very much acceptable. In terms of staff, I think, you know, making sure you have training and making sure that everybody's involved, not letting them self-select of who it you know, has a vested interest in that, and explaining, you know, why is it important, and not being too critical of people. You know, I think people are worried that, you know, they're going to come to sessions and we're going to blame them for not knowing, but nobody's blaming anybody. I would be very open, if people don't know things, to say that's fine. You know, let's start here and have a baseline of what we talk about. And also, I think just being very open about why it's important is the main thing, because that's the main thing that I find people say, you know, it's not relevant to me, it's none of my business. But you could say that about lots of things.
All right, thank you so much, Donna. That definitely does answer the question, and I think there's some really interesting points we can kind of pick up in the panel discussion as well. So thank you. I am aware of time, so I think I'm gonna, we'll take some more time in the panel to discuss further. But now, again, it's my pleasure to introduce Dr. Carey Candrian. She's an associate professor at the University of Colorado School of Medicine in the USA, and on the National Board of Directors at the GLMA, which is Health Professionals Advancing LGBTQ Equality. Her ultimate goal is to affect change during interactions between patients and healthcare practitioners, and also at policy level, so that older LGBTQ adults and their loved ones receive the support they want when they need it most. So, Carey Candrian, welcome, and thank you so much.
Thank you so much, Debbie, for having me, and let me go ahead and share my screen to make sure. Perfect. Thank you again for having me. It's really an honor to be here, and Donna, thank you for going first so I could wait till the sun came up here, and thank you for the magnificent talk. My pronouns are she, her, and in terms of appearance, I am wearing a blue sweater. I have blonde, increasingly gray hair, and I'm standing in front of a plant and a piece of art actually made by a queer artist here in Denver. What all of us know in palliative care is dealing with the end of life is hard. It's hard for everyone, but it is even harder for LGBT older adults. If you hear nothing else today, I hope you walk away understanding why. My research focuses on end-of-life care, specifically for LGBT older adults, those in their 60s, 70s, 80s, and even 90s. Why do I say it's harder for them? Basically, they're entering this last phase of life from a disadvantage in three main areas: financial security, family support, and the effects of a lifetime of stigma and discrimination. First, financial security. 1 out of 3 LGBT older adults in the US live at or below the poverty line. Second, family support. LGBT older adults are 2 to 3 times less likely to be married. They're 3 to 4 times less likely to have kids, and they're often estranged from their families of origin, as Donna mentioned. All this means is they're aging with a really thin network of support. Finally, the effects of a lifetime of stigma and discrimination. Research shows that this leads directly to higher rates of anxiety, depression, substance abuse, certain cancers, cardiovascular issues, and suicide. For much of my career, I've wanted to understand what specifically was contributing to these disparities and what we could do about it. So over the last several years, I've interviewed more than 75 older LGBT adults. One of them was Maggie. She's in her late 70s and lives alone in assisted living. She described the culture growing up and how people looked at anyone who was gay. Here she is.
They think there's something wrong with us. They think that it's not normal. Yeah, there's just something wrong, whether it's, mostly they think it's medical. You know, you got the wrong gene, or you got the wrong chromosome, or something like that, or you know, they don't understand how you got it.
They think there's something wrong with us. Growing up in the 1940s, the 50s, and even into the 1960s, being LGBT was completely outside of social norms. Up until 1973, I just found 1992 from Donna's talk, the American Psychiatric Association listed homosexuality as a mental illness. To give you a sense of just how pervasive these norms were, this is a woman named Pam. In this next clip, she talks about the 1961 film, The Children's Hour. Here she is.
It's Lillian Hellman, and in short, there's 2 young women who are running a girls' school, and it turns out that one is a lesbian and one isn't, and the one who is killed herself. So it's not a happy story, but for me it was fabulous to find out that that category of person existed. So I would say from 8th grade on, I kind of knew it, but the vocabulary, gay and owning dyke and all of that, didn't happen until basically after Stonewall. Stonewall happened when I was a senior in college, and so the vocabulary to describe myself came out in the 70s.
When Pam and millions of other older LGBT adults grew up, being gay or lesbian was unthinkable. It was even illegal in most places. I'm not as familiar with the laws for you all in the UK, but in the US at that time, if you were in public with a same-sex partner, even just holding hands, you could have been thrown in jail. You could have lost your job, you could have lost your home, and many did. It was just the norm. Here's Pam again.
It was the summer I was 21, about to go into my senior year of college. And up until then, it was incredibly dangerous to even think you were gay, but
Is it any wonder that older LGBT adults who grew up in this culture have honed a habit of silence about this core part of themselves for decades? It was a critical defense strategy, and this habit of silence still exists. 48% of LGBT adults say their own doctor does not even know they are LGBT. And they're not crazy for worrying and staying silent. Just last year, 56% of LGBT adults report experiencing some form of discrimination. For those who are trans or gender non-conforming, the number jumps to 70%. This kind of discrimination is happening all over the healthcare ecosystem. Everything from eye rolling to excluding partners and major decisions, disregarding patient wishes, abuse, outright denial of care. Hospice is no exception. In a 2020 survey of over 850 hospice professionals, 45% reported directly observing discriminatory behavior towards LGBTQ patients. A shocking number of seniors that I've worked with, older adults that I've worked with, didn't come out until their 70s or 80s. Imagine hiding something so central for so many years. And that hiding, the stress and stigma, takes a serious toll. Like I mentioned before, anxiety, depression, substance abuse, cardiovascular health issues, cancer burden, and suicide. And here's the big one. Staying silent about this fundamental part of themselves can take up to 12 years off their lives. Unfortunately, this will continue unless we make it clear that it's safe to share. This matters in all areas of healthcare, but it's critical around serious illness and palliative care. Here's an example. About 3 years ago, I interviewed a woman named Esther. She'd recently lost her wife, Kathy, to cancer. The thing was, when hospital staff realized they were a couple, Kathy's care got worse. So they felt like they had to hide their relationship. When I asked Esther what the hardest part of the whole thing was, I remember her saying, she was dying and I couldn't even say we were married. Since they were hiding their relationship, Esther couldn't be in the room. She couldn't talk with a care team about next steps. She couldn't advocate for her wife on any level. She couldn't even hold her wife's hand. When Kathy died, nothing. No one said a word to Esther. They had been together 33 years. What Esther's story reveals is that communication affected outcomes for two people. Kathy didn't have the support or advocacy she needed from the person she loved because Esther was shut out as non-family. And Esther got no grief support. She was just the good friend, the emergency contact, not a grieving spouse who just lost the love of her life. Just imagine how you would feel. Sadly, Esther and Kathy's story is not unique. This is a choice LGBT older adults face all the time. Do I come out and risk being treated poorly, risk not having my partner in the room, or do I stay silent and hide a fundamental part of who I am? That's a heck of a choice. On the one hand, we have documented discrimination and disparities in outcomes. On the other, we have people who are understandably worried about sharing this information. And it's all happening in a healthcare system that limits how people share critical information. Just think of our forms. Male or female, rarely is there another option, although this is improving. Single, married, divorced, widowed. What if you're Esther? Together 33 years, but not legally married. People say words matter, but it's more than that. The way we talk has an effect on people, positive and negative, that can either shut people out or bring them in. So what can we do? Legislation is one thing. Giving protections that are long overdue is a critical step, but we can't legislate the way people think and feel. What we can do is change the way we communicate, the way we talk and the way we listen to each other. One big way is what I call breaking the script. A lot of the way we interact in medicine is very scripted. The forms, the admission conversations, the patient interviews. And now a lot of these interactions are even dictated by drop-down menus and electronic medical records. We need to break these scripts, open them up in a way that gives people space to answer in a way that fits them and their lives. Take the burden off the patient so they don't have to be the ones that have to come out over and over again to a battery of new people when they are sick, scared, and exhausted. Just go back for a second and think about how we learn about our patients. Those forms, our intake questions, our admission conversations, even advanced care planning sessions. They're all critical tools in medicine, but scripted. They are loaded with assumptions, not spoken, but they're definitely heard. When the question is, are you married? How do you answer if you're not legally married and you grew up in this culture that I've been describing? Think about what we really need to know here. We don't care whether they're legally married. What we really care about is the who. Who will be caring for them at home? Who do they want in the room when we're talking about diagnosis, treatment, and planning? Who's able to make healthcare decisions if they can't? So what if, instead of asking, are you married, we asked, who's the biggest support in your life? Do you live with anyone? Just think how different the outcome could have been for Esther and Kathy. Countless people, particularly older LGBT adults, have been cut off by their families. Think of another script we often use in palliative care, the family meeting. What if, instead of making assumptions about someone's family, we asked, who do you consider family? Who will need support if something happens to you? I want to switch from the forms and talk about goals of care conversations, when people are telling you what and hopefully who matters most to them. This is Janelle, a woman who transitioned in her 60s. In one of our conversations, she told me her biggest fear. She's afraid that if she gets sick, no one will shave her face and she'll die as a man with a man's name. Where in our questions is there space for Janelle to disclose this information if she were to meet with a palliative care team or enroll in hospice? These stories aren't unique, but let's take a minute and zoom out and talk about the effects that this habit of silence has on a macro level. We need data, as Donna perfectly pointed out. We have pretty good demographic data on age, race, and ethnicity. We do not have great data on the LGBTQ community, in large part because we don't routinely ask sexual orientation and gender identity questions. LGBT people are often absent from a lot of the research and literature informing practice. Without good data, we don't even know how many LGBT people we're talking about, let alone how many are accessing things like palliative care and hospice, which means we really can't evaluate their outcomes or develop targeted interventions that actually could reduce some of these disparities. Funders often don't require these data, and SOGI data is often absent from a lot of these registries that are trying to improve quality. These structural disparities continue to keep this community hidden. Meanwhile, LGBT older adults have honed this habit of silence over decades. It becomes this almost wicked problem. We have to be proactive here at every level and every interaction to make sure we're asking these questions in a way that gives people space and doesn't perpetuate discrimination. So think about what you really need to know. Does the way you frame your question give space for lots of different types of answers? Imagine if you were trans and had to answer it, or if your family had rejected you, or if you're with a same-sex partner, but not actually married. Does your question shut them out or invite them in? Does it say, I'm okay with who you are and who you love? You're safe here. All the older LGBTQ adults I've met in my research, they are not asking for a lot. They just want to be able to talk openly and be heard without prejudice. And all we have to do is break these scripts a little. Give them space, show them we're safe, and listen. And the bonus will be, we'll finally get data on this community that has been hidden for so long. Thank you. And I do want to say thank you to Professor Jane Traves, whose book has been instrumental for me throughout my career, and particularly with this last study with older queer women. Thank you so much.
Thank you so much, Carey. That was an incredible talk. I can hear a bit of echo. I'm not sure if that's me. But yeah, I think the kind of what you said about breaking the script, I think really really hit home for me. I think kind of, you know, taking away the barriers so that people feel safe to speak. And I think what you said about that kind of habit of silence that's been built up, and just, you know, making sure that at every chance people are given the opportunity to share openly and in a way that is comfortable for them, is kind of really vital. I think one of the things that has kind of come out, because you've spoken, obviously this is research you've done with many people over years, and one of the questions that was asked through the audience was actually about how do you actually manage to reach LGBTQ plus people who are bereaved and make them feel safe to kind of speak to you about their experiences, and also kind of how long after the death of a loved one do you perceive it's okay to kind of to open up and have those conversations too?
Great question. So the first part, I think, how have I been able to find folks? I've used sort of every method. I think the one thing though that really is consistent is just time, patience, trust, and to really maintain these relationships. I do think, I mean, not that you need to be queer, but as a queer woman, I think it has made a difference insofar as I have been able to connect in a way that I really do feel it, I think, on another level. And I think that does, particularly for older LGBT adults, help with establishing this trust, particularly those who haven't come out in so long, well, for so many years, but to really feel like they can share it with someone who is part of the community has been one thing that has really helped. And I think staying in relationship, knowing that this is not, I don't want to interview them and never know anything about them. Esther, for example, we meet pretty frequently for coffee. And when I first met her, she was, a local paper wanted to do a story, and they had said, like, you know, we can't do this unless we talk with older LGBT adults. And I was like, I'm not sure I can't, you know, I can give you my perspective, but I can't do anything else. If they are willing, you know, they will reach out. And it took Esther a good about 8 months to even consider it. And now she's actually, she found a grief group, and now she said one of her biggest things was the world didn't know Kathy. And now the whole world knows Kathy, including London. So I think just the time and trust and building these relationships and knowing that you're not just using it for research, but you're actually, you know, using it to make a difference. And I think that link has been critical. I have completely forgotten the second part. Maybe I answered it.
No worries. The second part, that was, yeah, thank you so much for that first answer. And kind of, it's really moving to hear kind of what Esther's reflected on since then. The second part was just around kind of when you're speaking to people who've had these challenging experiences at end of life and through bereavement, how long would you tend to wait before you would kind of open up and kind of ask them to engage in discussion, or do you leave that kind of completely open to people to decide?
I really leave it open for them to decide. If they reach out and are interested, I let them guide it. If they feel ready to talk about, I would love to listen and be part of it. And if not, I would never, you know, it's on their terms, just like with Esther's with grief. I mean, I don't think you can put a timeline to it. I mean, she's 5 years out since Kathy's death and still very much feels the grief. So I think just letting the participant decide when they're ready to talk about feels the most right for me.
That's really helpful, yeah, and I think completely understand what you're saying about people being, you know, at different phases at different times. There's no set timeline, so yeah, absolutely makes sense. So Just looking at the time and thinking it would be a great point to move on to the next part of this session, which is the expert panel discussion. Before we do, I just want to say another massive thank you to Carey and Donna for your talks. I know you'll be part of this panel too. But what we'll be talking about is kind of having a real focus now on the next steps for LGBTQ plus women's research and practice. Before we kind of get going with the next part, we've got a couple more people that I'd love to welcome onto the panel. So first of all, there's Dr. Elizabeth Day. So Liz has worked with the Cicely Saunders Institute and has been a really invaluable part of the patient and public steering group member on several studies at the Cicely Saunders Institute. Liz, I know you have many hats, so if I can invite you just to say a bit more about yourself, that would be great.
Okay, thank you very much, Debbie. I'm sitting in City Lit, which is an institute in London where the Wi-Fi is dreadful. So if I keep disappearing, that's what's happening. So my pronouns are she, her. I'm a white, queer, cis woman. I also think I probably count Carey as an older adult because I'm 72. I've got spiky white hair with blue tips. And one of the things that I was thinking as I was listening to you both speaking is that what I'd forgotten to mention, I think, to anyone, I run a Facebook lesbian bereavement group. Most of the people who come to that, it's a twice-a-week Zoom group, are Americans. And it's extraordinary how isolated people are. I think there's less access and more difficulties than probably we have here. I'm also a psychotherapist, so and that's probably enough to say about me. Oh, and I know what I ought to say is that my partner Gabby died in May 2020 of cancer, and I have cancer myself. So I've been in touch with. I have the full palliative care experience.
Thank you, Liz. Really kind of helpful for us to understand both your kind of, professional experience, but also where you're coming from kind of in your own personal experience as well with palliative and end-of-life care. So also joining us on the panel now is Dr. Katherine Bristowe, who has led and been involved in several research studies about LGBT plus needs in palliative and end-of-life care. Katherine, can I invite you just to introduce yourself, please?
Sure, thank you so much for having me and for serendipitously organising it during my little toddler's nap. So if I do disappear, it's to manage a chaotic 21-month-old. But thank you so much for having me. I'm Katherine. I'm a lecturer at the Cicely Saunders Institute. I've worked in palliative care research for 11 years now. Prior to that, my background is in health communication research. I'm a linguist by training. So the fact that everybody's been talking about talking and words is absolutely at the heart of where I come from. In terms of my appearance, I am a slightly dishevelled, dark-haired, fair-skinned woman, and I am wearing a scarf in an attempt to be slightly more presentable because of the aforementioned toddler. So thank you all for having me.
Thank you, Katherine. That was a lovely introduction and really helpful for us to understand kind of all of the experience you've had, which I know is a lot in this area. So I guess kind of opening up the panel to discussion. So as I said, we're really focusing on kind of next steps. You know, what can we do going forward to support kind of better practice, both in research but also clinical practice. And I know we've heard a lot from our presenters already around this, and I think what Katherine alluded to there is a really nice kind of place to jump off. That we've heard a lot about the importance of communication, how questions are asked, how this comes into care, and I wanted to ask kind of, what can we do then, I suppose, to really encourage more allies? I think that there's been some recognition that a lot of people engage in this area because they might be LGBTQ plus themselves, and how can we kind of make this more of a welcoming space to encourage more people to step into it and be allies? Katherine, if you're happy to jump in, that's great.
Sure. I think one of the things that really struck me actually from Donna's presentation, and it's something that I hear again and again when I present about our work working with the LGBT community, is when people say, well, I've cared for a lot of gay men, but I've not cared for any lesbian women. And you think, well, the chances are that you have. And there's this invisibility and lack of awareness of that these individuals are there, and you've supported them throughout your career. And I think helping people to realise that they are allies is often the first point. I think there are people who are very visibly and vocally allies and who seek out to wear the lanyards, to wear the badges, to march at Pride. And there are those who deliver exquisite person-centred care day to day, but don't even see themselves as an ally, despite the fact that they are in every sense of the word. So I think that first step is really helping people to recognise quite what an important role it is, and quite how important it is. I think I presented this work to some medical students a few years back, baby medical students who were just in their first year. So, you know, they would have been born, gosh, where are we talking? Not around 2000. And I think what really struck me when presenting to them was they said, well, I don't understand why it's a problem, because, you know, gay people there's gay marriage, you can adopt children, there's legal protection. So I don't understand why people would even have a challenge in healthcare. So we've gone almost to the opposite extreme of that people are so aware of the progress, legal progress, that they're completely unaware that society is not there yet for a lot of people. So it's that real difficult challenge of both helping people to understand that there are still problems for many, many people, but also that their small contribution can make such a big difference, I suppose. Not sure if that helps.
Yeah, absolutely, Katherine. I think really interesting to reflect, like you say, on the progress that's been made, but then actually kind of also reminding people that we're not there yet, so we can't just kind of carry on, you know, as if everything's fine and everyone's getting exactly the support they need. Liz, I wonder if I could bring you in and ask you a little bit about your experiences, I suppose, and thoughts on that as well.
Well, I suppose interestingly, our experience was that we always introduced ourselves as partners every time we met anybody in health, which of course meant that we did come out all the time, but that's absolutely fine. And I think part of what happens is that I think we never gave people a chance to be embarrassed about whether they were going to ask or not. And if they got it wrong, and that happened a few times, then particularly when I've been talking, and people will then say your husband or he, and I just say no, she, or I say my wife died, because, and even sometimes having done that, people have not quite got it, but mostly they do. And it just makes it very clear for them and unambiguous. I think that's very helpful. I think people don't realise what small things you notice. What small things you notice that would put someone off talking about it or responding to the question. And I think if health professionals could understand what some of those very small things were, that might help them try not to do it.
Thanks, Liz. I think it might have jumped a little bit then potentially. But I heard the main points there, and I think it's really, I think kind of that thing where you're saying you felt you were kind of coming out all of the time to healthcare professionals, but you were making sure that, you know, despite that, people kind of weren't given a chance to be embarrassed. Clinicians were kind of aware of, you know, exactly where you stood and what you meant to each other, really. And I think that, I mean, that's really interesting in that, you know, I think you were kind of okay to do that. And I think I'm also very aware that we've heard of experiences, for example, in Carey's presentation from Esther, where they, you know, that despite kind of saying who they were to healthcare professionals, they weren't necessarily then provided that support afterwards. So I think it's kind of, making sure that people know who those partners are to each other, but also possibly being aware of then where to signpost to and how to support after that. Donna, I don't know if you had anything to add in terms of your experience as a clinician in terms of picking up on those points when, you know, how is that support ensured it's provided kind of to partners in practice?
Yeah, and I think it is fantastic when you have people like Liz and who's very open and is able to you know, not give people an opportunity to make the mistake and say, you know, we're partners or we're wives. But I think it's really important if people do that healthcare professionals like mirror that language that's used by the person. So if the person said, this is my partner, this is my wife, this is my girlfriend, that people use what, you know, write it down, even if it needs to be in quotation marks in the records, that is what the person's important person is. I have had the case where I've had a same-sex couple, and then people would refer to them as, oh, your friend is coming in. And I think, you know, there is a big difference between a friend and a partner, and people should be encouraged to use the language that's being used by the patient themselves. And I think, you know, Katherine made a really interesting point about medical students, and I've also had very similar experience myself when I've taught medical students now, is that they've grown up in a very different time. Even though I'm quite young myself, I'm only in my late 30s, there is a big difference between when I went to medical school and people who are medical students now in terms of their knowledge and the world around them. And I found that they had very similar views in that, oh, well, it isn't a problem, and they were very up to date with pronouns and the terminology and asking, and we're much more open than I think people of my age plus maybe. But then you have the problem that then they think that it's not a problem for older people, and they don't see how older people have lived with a life of having a stigmatized identity and the impact that's had. And I think that is a really important point. I suppose it's hard if people aren't forthcoming and feel they're able to say it. And I think our job is to make people feel safe. I know Liz alluded to there is behaviours that people do have that make people don't feel safe. I'm not sure if she can let us know more about what them behaviours are. And I think my focus would be think of ways that you can make people feel safe. I talked about the rainbow badge briefly and signs, and I think Carey made excellent points about you know, breaking the script in the conversation and giving people the opportunity to say who is important to you, who do you consider your family, rather than have a very strict narrative of you know, taking a history and expecting it to be a traditional setup with definitely having a husband and definitely having them forms of what we've had in the past.
Thanks, Donna. That's yeah, really useful to that kind of point about making sure that, yeah, professionals are making those patients and their significant others feel safe to share whenever they can. And yeah, absolutely, it would be really good to hear from Liz a little bit more. Thank you for flagging Donna on some of those experiences and those things that yeah, could be done or not done to make people feel safe to share.
Asking if Gabby was my business partner. Asking if Gabby was my business partner when I introduced her as my partner. I think it's very small things that I mean, I think it's the way sometimes people look at you, or they look surprised, or I've had people sort of look me up and down, and when I went for a mammogram, in a very sort of disapproving way because of the way I was dressed, and I suppose there's something about teaching people that we notice all those things, we notice them straight away.
I think Liz's signal is yeah, letting her down a little bit. So I might just pop over to you, Katherine, if you wanted to make the point you were going to.
Sure. I guess it was building on, Debbie's not mentioned, but she's been leading on a fantastic piece of research looking at communication and to develop some guidance really on how to make your language inclusive for everybody. And we've talked about this quite a bit already today, but actually a comment in the chat has reminded me that we also need to think about those individuals who are kinless, who don't have significant others, and that often our language is excluding for them as well. Is your husband going to be coming in, you know, or have you got a partner? So it's thinking through those careful ways, as Carey explained earlier, around who provides you with the most support and who matters most to you, I think is really important. And that it's not about developing a recipe or a set of guidance for when you believe you're faced with somebody from the LGBTQ community. This is about making your language inclusive from the outset. And the point that Donna raised about mirroring language is so important, because we have, in linguistics, we have theories around this, which is not only that this is really important for building relationships. If I was to call somebody my partner, then if somebody else then uses that term too, it's affirming for me. But it actually works in the reverse as well, and that actually we will choose different language to show that we don't agree with somebody. So if somebody refers to you as a partner and I correct that to husband, for example, then it's showing disapproval in the way that I'm talking. So not only can it work to bring you together, it can really distance people as well. So it's thinking about what can we do to make our language naturally inclusive from the outset to everybody, depending on their relationships, their identities, whether or not they've got somebody significant in their life, is really important.
Thank you, Katherine. That was yeah, really important point, Sarah, about you know, how do we ensure those who don't have partners are actually acknowledged and cared for properly as well. And Carey, I wonder if I can invite you in, because obviously we heard a lot from you around the language it's used and how we actually break the script for people who you know, don't have partners. How do we ensure that it's done inclusively?
Yeah, and I'm so grateful just to be having this conversation, because I feel like it already is pushing, I think, so a lot of the LGBTQ papers, I think, are sort of like the paper that more training is needing, communication matters, but very little is actually, except you all are an exception for real coming out of King's College, but actually giving people concrete examples of what to use to, I mean, which feels like we're replacing a script with another script. But I think in doing that, it helps people realize, like, their questions have consequences. What I was trying to show too, like, it affects people when you ask if you have a husband, if you ask you have kids. And I think bringing awareness to people, best of intentions, aren't really even aware of the impact that these questions have. Particularly for the older generation, and particularly when you're dealing with something like serious illness. So I think exactly, I mean, with a background in communication, giving people very real concrete ways to ask these questions differently, as opposed to just saying, you know, do more training or communication matters. What can people actually do that would make a difference and give people the space?
Thank you, Carey. That's really helpful, and I think that whole kind of point around, you know, words mean something, questions have consequences. It's such a strong one. You know, they're not just, you know, people aren't kind of voids and it just kind of goes and they're fine and they kind of carry on as they were, as if, you know, nothing happened. And yeah, so I think that's so important for us to think about the language that is used, and yeah, appreciate kind of you talking about the fact that, or at least acknowledging that, you know, are we potentially just giving people another script? But I was thinking as you were saying that, you know, as long as that those kind of suggestions and the kind of script we provide is one that allows open conversation, then hopefully that's a little better than the kind of drop downs and things that might potentially be in existence already. Liz, I know that you're back with us now. We lost you a little bit before, so I wanted to just give you the opportunity to come in and finish what you were saying previously.
What I was going to say is, I think people need to practice asking the questions. It's no good just knowing what they should be. You need to actually practice them so you can ask them in a way that feels natural.
Yeah, I think that's such an important point as well, Liz. So thank you. I think that kind of, you know, we've heard from, I think, all of the presenters and people who've spoken today about how this might be kind of something different in practice, but making people feel kind of safe in those discussions is really important. And I guess if you're not very natural or comfortable in just even asking or talking about this yourself, that's probably going to show through. Because I think, Liz, you also alluded to some of those kind of non-verbal things, that those non-verbal signals that people might give when in discussions. So whilst words are vital, we know it's not just about words and not just about what's said. So I wanted to, I'm kind of aware of the time, but one of the things that I just wanted to ask about was, I think, Donna, you spoke about in your presentation about, and I guess thinking about the non-verbal signals, about the kind of complexity now of the rainbow badge, what that means, how we actually signify to people that kind of, you know, we might know something, and we're very kind of open to those discussions. I wonder if people had any ideas on potential solutions, next steps for how we might overcome that challenge. Carey, apologies, I'm aware that kind of the NHS rainbow and the LGBTQ plus rainbows are probably not such an issue in the US. But yeah, Donna, I don't know if there were any thoughts you've had on kind of what we do next then. What's the next step?
Yeah, I'm not sure. I think, you know, we are carefully kind of disentangling the rainbow and the rainbow badge, and I'm still, you know, I still think it's very much worthwhile, not even the fact of wearing the badge, but getting people to do the pledge, because it raises more awareness with staff. But I guess going back to what Liz was saying about practicing the conversation, if it's no use waiting until you see somebody who you think might be gay to bring up the conversation, because then you're waiting until you have the assumption. You need to practice the conversation with everybody, because you don't know what people's backgrounds are. So you should be having them conversations with everybody that you see. And by having the conversations with everybody that you see, you're giving people the, you know, the sign that it's okay. You know, you talk about this with everybody. It's the same with like other serious conversations. You know, you normalize it and say, you know, oh, I talked to everybody about this, so I'm, you know, gonna to be very open and have an open discussion about sexual orientation, who's important to you. So by bringing it up in all, you know, all with all patients, then you're kind of showing, and it becomes more comfortable, and it becomes more obvious that you're experienced and confident in talking about those issues. I think now we've got pronoun badges as well, which is another good move. And somebody's asking the questions, what is one of the things that people didn't know? And a lot of people didn't know what pronouns were and what pronouns were for. And that's along a very similar thread, in that people think, well, why do I need it? I'm cis, I don't need to have it. But the whole point is, you know, you wear it because you're making it, you know, acceptable that everybody has one. If it's only the people who aren't have one, or, you know, have pronouns that are different from what you'd expect, then that defeats the point. So I guess overall, my very long way of saying an answer is that, you know, practice having the conversations with everybody to, you know, make it more comfortable.
Thank you, Donna. That was really, yeah, really helpful kind of next steps in terms of the visual side of things, but also, yeah, just reiterating, I think, that practice side. And I think that kind of, yeah, leads me into, you know, for those who kind of obviously are all specialists or have experience in this area, I mean, what do you think would be your kind of top, I guess, next step, next tip for people who want to ensure they're providing inclusive care? I'm aware of the time, so thinking this, we maybe go around and one person kind of just, yeah, everyone says one thing. So Donna, I think you kind of said pronouns, and so Carey, I wonder kind of what you might say for, you know, ensuring inclusivity and those who want to kind of improve their practice. What would be your top tip?
I think changing one of the scripts you're currently using that you might not even be aware of. So whether it's, you know, who do you consider family, who needs to be in the room, who's the most important, just changing one of those to really get at what Liz said, to really practice how this feels and change the habit would be my takeaway.
Wonderful, thank you, Carey. I will come down to Liz next then, if that's all right.
I think rehearsal is just so important, because my experience of teaching people to ask about people's drug and alcohol use is that unless you coach them and get them to do it, they actually don't do it. You know, 10 minutes into the interview and they still haven't asked when you were wanting them to ask in the first couple of minutes. But if you keep making them do it, then they get used to it, and then they will, and it'll feel okay for them.
Yeah, okay, thank you, Liz. So yeah, kind of reiterating a bit that script, and also that, you know, changing one thing is really helpful. And I think and then if we've got the pronouns badge that Donna's mentioned, potentially maybe the rainbow one too, as long as that retains meaning. And Katherine, can I invite you just to share one?
Yeah, I guess my tag onto those vital things would be accept that you're human and accept that your knowledge has limits. And if somebody was to be under your care and was from a faith that you're not familiar with, you wouldn't hesitate to ask them about what it means to them, how you can help them to feel supported. So accept that sometimes you will make mistakes, accept that you've made a mistake, apologize and move on and learn. And if you don't know, ask. It's important that you show authenticity in yourself as a professional by showing interest and showing that things matter. So just remember you're human, I think would be my take-home message.
Thank you so much, Katherine. And yeah, thank you again. I mean, we're pretty much at the end of the event now, and I think there were some incredible things for our attendees to take away and take forward in practice. So yeah, I think it was such a valuable event, and thanks for all of the attendees who have joined us virtually as well. I've really enjoyed the session and think we've kind of really moved forward in terms of, you know, what next, what can we do in practice to improve that care. I would just add that I guess at the beginning of the talk I mentioned intersectionality, and we've heard all of the brilliant talks and speakers today, and it kind of took me back to an interview with Kimberly Crenshaw a few years ago, and she reminded us that it isn't acceptable to simply flag how complex these intersections are, and actually what we need to do is do something about it. And I think that's what all of our speakers have really helped us reflect on today. So thank you so much, and I will end with just, yeah, praise for everyone and thanks for all of your time and contributions.